site, to the research that you are doing. Wherever you go, we hope you will take a little, at least one nugget, if not more, from what you hear today and bring it back with you. On November 14th, we will hear from Harvey Rubin. Dr. Rubin is the director of the Institute for Strategic Threat Analysis and Response at the University of Pennsylvania, and he'll be talking about the creation and implementation of a global governance structure for infectious diseases. On December 5th, our grand round speaker will be Dr. Jeffrey Brenner, executive director of the Camden Coalition of Healthcare Providers. Dr. Brenner has focused much of his work on high healthcare users in Camden and developing health and social service systems to meet their needs. And he was the winner recently, this recent round of MacArthur Genius Award. So he will be with us in December. And those will both be here at 4:30. In January, the School of Public Health is moving across the river to the University City campus, and we will be relocating our grand rounds there, though we don't quite know where just yet, but we will get back to you on that. We will be hearing from Dr. Paul Offit, who's the Chief of Infectious Disease at CHOP, Dr. Don Schwartz, who is our own Deputy Mayor and Health Commissioner, our new Dean, Dr. Ana Diaz-Rue, and several other speakers that we're in the process of lining up. So stay tuned for details on those and other grand rounds for 2014. I also want to invite you afterwards. We'll have a light reception just in the lobby outside here if you want to stick around and talk to your colleagues and get to meet some other new people while you're here. So finally, it is my great pleasure to introduce our speaker today, Dr. Lydia Ogden. Lydia Ogden became the Executive Director for Vaccine Global Policy at Merck in November of 2012, leading expanded access to immunizations worldwide. Prior to joining Merck, Dr. Ogden worked for more than 2 decades at the U.S. Centers for Disease Control and Prevention, most recently directing the Office of Health Reform Strategy, Policy, and Coordination. From June to December 2010, she served as the Senior Health Policy Advisor to President Obama's National Commission on Fiscal Responsibility and Reform, counseling on changes needed to contain U.S. health expenditures while preserving quality and increasing value for spending in Medicare, Medicaid, and the plan's state-based insurance exchanges. Dr. Ogden holds a doctorate in health services research and health policy from Emory University and a master's degree in public policy from the Kennedy School of Government at Harvard. She holds a faculty appointment in the Department of Health Policy and Management at Emory University's Rollins School of Public Health, where she teaches U.S. health policy. Please join me in welcoming Dr. Lydia Ogden.
So while we're getting the tech fixed, everybody can hear me, right? Because sometimes I don't project very well on these kind of mics. There I am. Awesome. Thank you.
Wait, just a second. Yep, that's right.
Thank you. I'm armed and dangerous now. Okay, everybody, thank you for coming. It's a real pleasure to be here. And before I launch into the presentation, I would like to say I would like it to be less of a presentation than a discussion. So stop me at any time. Shout out a question. I want to do that. Shouts of discontent are welcome. Anyway, we're going to start with a quiz. True or false? The U.S. has socialized medicine. True? One person. False? I'm assuming the rest of you? The true people. What's our socialized medicine system? Medicare. Right? So when people say, oh my God, we can't have socialized medicine in the United States, you should say, excuse me, we already do, and we have had since 1965. Number 2, in 2013, health spending in the U.S. was, or is, A, mostly privately funded, B, mostly publicly funded, or C, about the same. A, private, B, public, about half of you, and C, roughly about the same. It's roughly about the same, all right? We spend a lot of money on health care in this country, and it's about half privately funded and about half publicly funded, and we'll talk about that in a little bit. The average beneficiary pays what percentage of her lifetime Medicare health expenditures? That is, by the time she's paid into the system through payroll, taxes, et cetera, and then she spends out of the system over her lifetime, what's that ratio? 0 to 10%, meaning that's what she's covered. 15 to 20%, that's what she's covered. 33 to 50%, or D, 75%. A, 0 to 10. B, 15 to 20. C, 33 to 50. Or D, 75%. Some of you aren't voting. That's so American. The answer is C, between 33 and 50%. Who is paying the rest? Raise your hand if you pay taxes in this country. You are paying the rest, right? That's important. Number 4, public health spending represents what percentage of overall health expenditures in the U.S.? Is it 1%, 5%, 10%, or 3? A, 1%. B, 5%. C, 10%. Or D, 3%. Ding, 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 ding. It's 3%. Good job, you guys. Number 5, the typical adult is up to date on what percentage of recommended clinical preventive services. So that's things like mammograms, vaccinations, colonoscopies, blood pressure checks, etc. Is it 3/4 of those recommended services? Is it 1/3 of them? Is it half of them? Or is it 1/4? A, 75%? That's right. B, 33%? C, half of them? Or D, 1/4 of them? So the answer is actually all of the above, depending on who you are, what gender you are, what insurance you have, etc. But on average, it's just 33%, right? And that has implications for health spending, because is preventive care more or less expensive than restorative care? Less, exactly. So we're going to talk a little bit about that. This is what's happening in America and will be happening for the next little bit. Rising healthcare spending, demographic changes, mostly the silver tsunami of baby boomers who are hitting Medicare age. Anybody know how many people turn 65 every day in this country? Take a guess. 100? No. 1,000? No. 5,000? No. Between 8 and 10,000 people turn 65 every day and will do so for the next 20 years. That's a lot of people. And what happens when they turn 65? They get Medicare, right? And remember who's paying for that? All of you guys. And mounting and fiscal and budgetary pressures at not just the federal level, but also state and local governments. It's getting slightly better now that the economy's picked up a little bit, but it's still pretty grim out there in state and locals. So we'll talk a little bit about that. This is a look at the fiscal year 14 federal budget. So defense, Social Security, and healthcare, and other mandatory programs, who's good at math, add up to what percent? 16% plus 23% is? 39 plus 25 is? 54? 64 plus another 16 is? That's why some people call the U.S. government an insurance agent with an army, right? Because all this stuff is mandatory spending. It's health care. It's what used to be called WIC, HANA, food support programs, SNAP, et cetera, et cetera. Interest on the debt is currently 6% of federal spending. But as our debt gets bigger, what happens to that? It gets bigger, right? And as all that mandatory spending, because, by the way, we can't just not pay the interest on our debt, right? Right? What happens if you just don't pay your credit card bill? So they either cut you off or they come knocking on your door, right? So as all of that mandatory spending inexorably grows, because more and more people go into Medicare, Medicaid is going to grow somewhat due to health reform. Spending on subsidies for the health insurance exchanges will also go into that current 25% for health care programs. What happens to the all other programs, absent new sources of revenue? it inexorably gets shrunk, right? What's in the all other programs? Education, infrastructure, parks, CDC, NIH, FDA. That's the all other. That's the all other. Everything else the federal government does, right? Pretty sobering. And on top of that, the federal government currently borrows 41 cents out of every dollar it spends. Where is it borrowing that money from? From you, right? We're going to talk about where it's coming from in a minute. This is a quick look at how our debt, which is the red bars, has risen over time. It's now close to, it's actually topping $16 trillion. And the interest on the debt has grown over time, fell a little bit this year. So, I think I actually have to enter this to make the graphic work. That's how much you owed if you're a taxpayer this morning when I checked. Okay? Yeah, if you don't know the debt clock, let me see if I can get this hyperlink to work. I can't in here. So just go to debtclock.org. It's really scary. In fact, it's what we use to scare our children at home. Oh, I wish that could work. I'm really sorry that won't work. Wait a minute, maybe it will. Nope, it won't. So this is who holds the debt. The part that's represented by the flag is us, the taxpayers, and people who have T-bills and things like that. And the other 46%, roughly half, is foreign nations. And who's the largest holder of the United States debt? China. That's right. And so, in our recent government shutdown and debt discussion that didn't go so very well, there were some concerns expressed by the Chinese as the largest holder of our debt. So they're not likely to call the debt, right? They're not likely to say, okay, pay up now. But what are they likely to do? Raise the interest rate and make it more difficult for us to borrow more money. Or, they might conceivably impose some trade sanctions or bring some other concessions out of the U.S. government. Okay, so that's why our health spending drives our annual deficits, and which drives our total structural debt, which actually affects our foreign policy, right? It's like 6 degrees of separation with Kevin Bacon. How health spending affects foreign policy in 4 easy steps. So the bottom line is we simply cannot keep doing what we're doing. We can't keep spending money we don't have to finance health care that actually, by some standards, doesn't really represent a very good value for the spending, right? Where does the U.S. stand on things like blood pressure under control, low birth weight babies, premature birth rates, premature death rates? Not so great. So all that money that we're spending arguably isn't a very good spend. And I had a chart in here. I may have skipped it. Oh, no. Here it is. So this is what we have spent this year. Almost $3 trillion on health care in the United States. Everything that's colored green is some kind of health care service. In either acute care, hospital care, which is the largest chunk of it, or clinical care in a physician's office, other professional services. Now, it's not that this is all bad spending. It's just a lot of spending. $2.1 trillion in direct health care services, right? And so governmental public health, which is that last little wedge, is 3%. And that's everything that CDC does and state and locals do. This is all rolled up into our national health expenditures information. So this is the chart I was looking for. This is how we spend comparatively right, compared to other developed countries. This is the OECD, the Organization for Economic Cooperation and Development, OECD. So it's countries like Australia, countries like the UK, we're 2.5 times the OECD average. And arguably, we're not getting any better value for that spending. And in some cases, worse. Right? So as an economist, you have to say, that doesn't make a lot of sense from a value proposition standpoint. And thus, the logic of health reform, right? The logic model here, and this is very linear. We all know that the world isn't linear. But this is where we started. We started by expanding insurance coverage. That's what ACA mostly did. There were some modest nods to better care through actually making all those preventive services that we talked about that people aren't getting no cost sharing to holders. So things like mammograms, things like vaccinations, things like colonoscopies, et cetera. Those are all at no cost sharing. So, and there's, in the law, there is an emphasis on expanding primary care through higher payments to primary care physicians. The law also seeks to increase supply of physicians and other healthcare providers to meet the anticipated additional demand. But that's pretty much where health reform stopped, right? The system wasn't terribly reorganized. So when you hear people say, this is a government takeover of healthcare, it's actually not. I'm probably one of the few people in the United States who've read every single page of the law, and it's about this thick. If the government were going to take over healthcare, it would be about one page, and it would say, the government now runs healthcare. And that's not what this law says. So everything that's over on this side of this logic model has largely been left yet to be determined by the law and by the evolution of the system. So we're a long way from reducing health spending through this law. And that's what I spent my time at CDC in the Office of Health Reform figuring out. How do we get from here all the way over there through incentivizing prevention in the healthcare system? Because right now the incentives in the healthcare system don't run to prevention. Doctors don't get paid for preventing things, by and large. And if you are a diabetes doctor, CDC's obesity prevention and diabetes prevention programs mean your kid isn't going to go to that fancy Ivy League college on your nickel, right? So the incentives run against doing the things that public health wants to do, which is to reduce disease and disability. Here's the other problem, and this is what we're living through right now. You cannot separate the implementation of a policy from the actual development of the policy, and that's why that incredibly long 2,000-page law is going to be really, 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 really complicated to implement. And we're seeing that now. The website, did anybody go on the website, by the way, to try to get, and how was it? It worked well? That's awesome, because when I went on, I couldn't get in, right? Now, that doesn't mean the law is bad. I saw a great letter in the New York Times earlier this week that said, you know, if the computer that you were trying to read Twelfth Night on failed, you wouldn't say Shakespeare couldn't write. Good point. But the problem is the law is really complicated because it's touching a fifth of our economy. That's not easy to change. And so I've actually had an opportunity recently to reconnect with some of my students at Emory whom I haven't seen since I taught the health policy class, which was all about the Affordable Care Act last year. And they've been emailing saying, how did you know this was going to happen? Because everything that I had told them in class has pretty much happened, which is that what the strategy is going to be is to delay, 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 and defund, 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 defund. Because if you can't fund, somebody asked me, it was actually my husband, who's sitting in the back of the room. His name is Jim Bueller, and he actually teaches here. And he said, how come this website isn't working? And I said, because CMS, the Centers for Medicare and Medicaid Services, doesn't build websites. They pay bills. That's what they do. They write checks to pay bills, either to doctors or, et cetera. They don't build websites. They don't sell consumer anything. They're not Amazon. They're not Expedia. They don't know how to do this. And on top of that, Congress actually didn't give them money for the staff and the implementation that they needed to be able to build the website, right? So what these two very simple graphs try to display is that if there's a lot of very intense positive interest for a public policy, and there's sufficient resources to implement that policy, you're not going to have delay. You're going to be way out there on low delay. In contrast, if there's intense negative interest, and was there about Affordable Care Act? Yeah. And you can shrink the and the resource level is low, which there has been insufficient resource allocated, then delay is going to be high. So we've seen that with the exchanges, right? That in the states that built their own exchange portals, the story's pretty good. Seems to be going pretty well. People seem to be pretty happy. Federal website, not so much. And in fact, in Pennsylvania, we've got a federal exchange operating here, right? So the people here in Pennsylvania are apt to be way more frustrated than the people in California, whose state has been working on their exchange for quite a while now. So what happens if you're in a state that's not expanding Medicaid? What happens to you? And you're not eligible for the exchange. You're SOL, as the saying goes, right? Because all the incentives in this system run to a state saying, yeah, we're not going to expand. We'll let the federal government do it, because then you don't have to pay for it as that non-expanding state. And taxpayers in other states do have to pay for it, right? So the bottom line is it's just not clear how the Medicaid expansion is or isn't going to go. States are still kind of in the process of deciding. And by the way, the federal government has given them no deadline. They could decide at any point that they want to expand. So a quick look at who those people are. These are people on the left who will be newly eligible. What's something that you notice about this age spread from the people who are currently to newly eligible? Where's the biggest growth? Yes, who said middle age? That's exactly right. And what do we know about people who are, let's see, this one, 55 to 64 versus the next largest group, which is the 19 to 24. Are the people who are newly eligible for Medicaid, who are 55 to 64, likely to be pretty healthy? No, because probably many of them have gone without insurance for quite a while, right? In contrast to, we would hope that the younger people will be healthier. And how does insurance work? It spreads risk, right? So you really need those young people who are healthy to be paying into the system and not consuming so much care on the presumption that they're going to be cross-subsidizing the older people who are needing more care, right? So that's one thing to kind of flag, right? And who are they mostly? Men more than women. Although a significant chunk of women, right? Because men historically were not eligible for Medicaid, although many states over the years expanded their programs to include men. So the bottom line is there's a lot of variability across the states. The state that I came from, Georgia, had an awful lot of uninsured people and was totally unwilling to expand its Medicaid program. The majority of them are male, as we noted, but a significant chunk of them are women of reproductive age. And that's expensive, right? Medicaid already covers what percent of births in this country? More than half of all births. And, many times, being pregnant and delivering a baby is expensive enough. If you're in poor underlying health before you get pregnant, or you have a difficult pregnancy, it's going to be even more expensive. And a significant number of them are parents who have dependent kids at home, most of whom are already covered. So that's just kind of a quick snapshot of who we're talking about. But even so, there are going to be a lot of uninsured people in this country. In 2014, 44 million, equivalent to the populations of Maryland and California. It'll fall to 37 million, we predict and hope, in 2015, and fall again to 31 million in 2016. But from there on out, it'll remain about steady, 29 to 30 million people uninsured in this country going forward. So when people say, we don't want universal health care in America like they have in those socialist systems in Europe, you can say, okay, well, we didn't get that with health care reform, because this is a lot of people who are going to remain uninsured. And the bottom line for public health, what that means is there'll be a significant ongoing need for safety net services, because public health has become the safety net provider in this country. Yes, ma'am. Why would uninsured people go down over time? Because there's a very modest penalty. Quite frankly, the penalties, if you were thinking in economic terms, you would say, I'll just pay the penalty, right? Unless you were risk averse, which I am. I don't want to take the risk that I'm going to step out here and get run over by a SEPTA bus. And, that would be really expensive, right? So I want to insure against that. It will also go down over time because more states actually might expand their Medicaid programs, or because the economy would pick up, right? And Medicaid is what's known as a counter-cyclical program. That is, when the economy tanks, need for Medicaid goes up because more people fall under the poverty threshold for Medicaid. The number of uninsured might also go down over time because we could have demographic shifts, more people moving into Medicare, for example. We could have a mass exodus. Texas could succeed in seceding. You don't mess with Texas. Other questions? Okay. So against this backdrop, before I left CDC, I asked the question, well, what are local health departments doing in the realm of healthcare? Because the notion was that public health was somehow going to be part of this grand health system transformation. And we were going to become part of accountable care organizations and that kind of thing. And I'll confess to you right now, that is a wacky notion to me, because I just don't see how healthcare will ever be a patient-centered medical home. I mean, how public health will ever be able to be a patient-centered medical home unless that local health department is operating as an FQHC. And no small number of them do. Of the 75 counties in Tennessee, plus, there are 75 county health departments that are operating as FQHCs, which I find really fascinating. But by and large, if I were just stepping back to design a system, that's not the system I would design. Because public health has really great skills in epi and capacity and restaurant inspections, but not in providing obstetrical care, which is one of the things that local health departments are actually doing, right? And that's antithetical to one of the notions of health reform, which is we would defragment our system. We would make our system more coherent. We would reduce the likelihood that a patient with chronic conditions will see 5 different physicians in a year. None of those physicians will talk to each other. They'll all prescribe something different, and at best, the care might be ineffective, and at worst, it might be actually harmful, right? I don't see how public health can play coherently in that environment. Local health departments, these are the providing screenings. Now, screenings are okay, but then if you screen somebody, don't you have an obligation to actually do something about that, right? You don't want to screen somebody and then say, oh, yeah, you have high blood pressure. See ya. You want to do something about that. So against this backdrop, the Association of State and Territorial Health Officials, or ASTO, developed what they called a roadmap or a strategic map for primary care and public health integration. Somehow, public health will maybe do the screenings, and then they'll manage to not only refer, but actually hand walk people into primary care where they'll transition them over. So based on all of my experience in public health and my experience at the Fiscal Commission, what do you think the biggest hurdle? Is it A, B, C, D, or E here? If you're putting on my economist hat. Oh, sorry, is it too small? A is identify and create demonstrated successes. That's perennially a challenge for public health. B is realign funding to support coordination and sustainability. C is disseminate and scale effective approaches and systems. D, develop and implement effective measures of population health. Or E, create the infrastructure to support collaboration and sustainability. What's the biggest hurdle there? E? Money. It's the money. It's B. Because is that health system going to want to give up money to public health? We're at what percent now? 3. We're not going to like zoom up to 5%, right? Because that healthcare system is being buffeted now. It's seeing its resources shrinking and a lot of pressure to shrink those resources. So they're not going to just write checks to public health. And if public health is part of an ACO, that's performance-based activity like public health has never, ever seen. Because in public health, what happens when your disease rates go up? You get more money, many times. I mean, look at, if you could do a historical tracking of TB rates and money, you would see what I'm talking about. That they would cut the money, and TB would go up, and then we'd give more money. You know, so that's what happens in public health. You get enough epi information, surveillance stats, and you show it to the policymakers, and they go, wow, we've got a problem. And they give you money, in theory. All right, so these are some of the big questions that we were grappling with at CDC before I left. The big one is, should local health agencies provide those direct services? Should the Norristown Health Department be providing OB care? Right? And should CDC fund that? Should public health funding be used to pay for services for insured individuals? That was a big one. Right now we have public health money that's used for immunization. It's used for a variety of screenings, STD-related screenings, HIV, hepatitis, and it's used for the breast and cervical cancer program at CDC to fund breast and cervical cancer screenings for women. But in theory, and this was what we had to disabuse people of, because even in our own government, people at the Office of Management and Budget were saying, well, everybody's going to be insured, so you don't need those screening programs because they can just go to their doctor. Well, not so much, right? Because even if you have insurance, you might not want to go to your doctor and be tested for GC. And more importantly, remember all those colorful states that I showed you. There are going to be a lot of uninsured people in this country still. So we had a job at CDC to explain, even to our own government, that not everybody's going to be covered. You think they would have known that, but they didn't. So that was a problem. This is the big question, the money question. Can public health somehow capture reimbursement? Or in other words, can they bill? Can public health bill Medicaid? Can public health bill Blue Cross Blue Shield? Right? And in some jurisdictions, in some states, public health is actually precluded from billing because public health services are seen as just that. They should be for the benefit of population health, and they should be free. Immunization should be free. Right? And so in particular, there are real implications for billing Medicaid because public health is part of a state public health department. So is Medicaid. So it's like billing your brother, right? And state budgets are what state budgets are. The only difference is that for Medicaid, the federal government chips in a fair amount of it. So there's actually this little interesting fiscal game going on in many states where public health is billing Medicaid because who's picking up the majority of the tab? The feds, not the state, right? But it still raises very kind of thorny and troubling fiscal questions about state fiscal capacity and sustainability. I also had these, nightmare visions of, poor people coming into a local health department and presenting for care, and the health department getting a billing, and then, how are they going to hound those people for payment when they don't pay, right? That's not what happens at a federally qualified health center. You pay on your ability to pay, and if you can't pay, you don't pay. But public health just hasn't quite figured out that this isn't as simple as having, one of those old-fashioned credit card machines in the, on the front desk. There are a lot of back office functions that are complicated, right? So all the public health folks who had dollar signs in their eyes, I kept saying, I don't think health reform is going to be the way out of the perennial underfunding of public health in the United States. And it is shameful the way public health has been underfunded. On the other hand, I spent more than 2 decades at CDC trying to explain to Congress what they were getting for their money. And I often was unable to do that, right? When I would say to my colleagues in a program at CDC, what's the ROI on this investment? They were like, what? What's an ROI? We don't even know what that is. Because public health doesn't have a bottom line imperative in the same way that the private sector does. But we still have an obligation to be good stewards of the taxpayers' money. And we're often not. That's our dirty little secret. We're often not good stewards, or even if we are, let's give ourselves the benefit of the doubt, we don't do a good job of explaining exactly what people have gotten for their money. And I think that's wrong. So other questions are, what new partners do we need in this transforming system? What about all those electronic health records people? That's a gold mine of data, right? That would be exciting to get our hands on. But I don't think that we've quite figured that out yet. And what new knowledge, skills, and abilities, or KSAs, do public health practitioners need? So in my class at the Emory School of Public Health, we spent an entire semester on what I've just covered in 15 minutes. Because I think we can't turn public health people out of our doors any longer without them understanding how healthcare is bought and paid for in this country and the implications of that, right? And how to work with this crazy system. I cannot tell you the number of my colleagues at CDC who would, even after a long time would say, now, okay, Medicaid, that's the one for old people, right? No. Medicare is the one for older people. And, oh, by the way, disabled people, right? And it's socialized medicine and, et cetera, et cetera, et cetera. So this is our best opportunity for public health because we're spending a lot more money on health care than we are on public health in this country. And we can achieve incredible population health gains if we work strategically and cleverly with that larger healthcare system. But the way to work with it is not to see it as a cash cow, which is how some people in public health do see it. And so I don't think we've quite figured out how to use that little cog to move that big population health cog. And so with that, I'll close, and there's a big, long discussion about the debt and the deficit, which you don't want to get into. So I'll close, and I'll take your questions and comments.
I'm going to ask folks to, where's my mic person? Thank you, Dr. Ogden. That was perfect. We're going to ask you to speak into the mic when you ask your questions so that we can record your every last word.
First question?
Oh, I thought you were running up to ask a question.
Hi, how are you? Because of the healthcare regulation that makes sure private health insurance companies spend a higher percentage of their income on actual healthcare spending, wouldn't this drive down the costs of coverage and increase coverage essentially in a way that's more than what was modeled in your slide?
So the question is, now as part of the law, private insurance companies are required to spend a certain percentage of what they take in on health services, a certain percentage of the premium. For simplicity's sake, we'll say that's now 85%. It varies, right? But what's the hitch there? It's defining what health services are, right? So can providing health information and increasing health literacy be considered legitimate under that? Those of you who are in behavioral sciences, you would say, shoot, yeah, right? But does it have to be a service? What counts as a service? And does advertising that your insurance company exists, does that count under that, right? So it's not clear what the implications are. And remember that providing services in the context of the U.S. is more often than not preventive services, although they would be covered. It's restorative care, right? And the other kind of scary thing, and think about the prevention continuum, from primary prevention, for example, an immunization, and let's say an HPV immunization, to secondary prevention, which is screening for cervical cancer, your annual PAP, to tertiary prevention, which is actually intervening if you find, a lesion. Right? HPV vaccination costs X amount of dollars. And if I'm Blue Cross Blue Shield and I'm paying for the vaccination of that 12-year-old girl, who's going to reap the benefit of her not having cervical cancer? Is it going to be Blue Cross Blue Shield? Probably not, because she's probably not going to be Blue Cross Blue Shield insured when she's 45, right? What about a screening? If we screen more people, as we get all these now currently uninsured people into the system, and they're screened for things like cervical cancer or hypertension, what's going to happen? We're going to find people who need intervention, right? So what's going to happen? Costs are going to go up in the short term. Prevention's ROI is out years, and we just haven't quite got that fiscal cadence down yet. I mean, it's a good question, and certainly everybody's hoping that by more spending, that more of it will be preventive, or that it'll be timely and will ward off even more expensive problems later on, but the jury's out on that. Other questions?
Thank you for your talk. I have a question about reimbursements. And there's a huge range of reimbursements across the insurance industry, notably Medicaid, which reimburses at a much lower rate than other insurers. And I guess I'm interested in your thoughts about what the future holds. And I mean, I know a lot of providers that won't take Medicaid. Do you see this as a boon for the FQHCs? And how do you see this resolving itself?
Good questions. And so money makes the world go round, right? One of the things the law did was actually increase Medicaid payments to bring them up to Medicare level. So that's a step in the right direction. But there's no question that constraints on the system are making people very anxious. And one of the problems with Medicaid patients and you know, not a not inconsequential number of Medicare patients is that they have multiple chronic conditions, and they're just expensive. And because of the fragmentation in the system, they're often not cared for very well. They're often not easy to care for either. They're, you know, not particularly adherent, and, you know, they miss appointments, and they're really, so it's difficult. But there are some awesome models out there, including a really fantastic model that's operating in Camden. So when the speaker comes from Camden, you should ask about this, because they're doing some amazing things with Medicaid populations in Camden to, you know, do patient-centered medical home and to do, you know, on-time, timely patient management and holistic care, and actually seeing reductions in spending, even for patients with multiple chronic conditions. To put on, you know, my forecaster hat, I think the pressures on the system are going to continue to exacerbate as the rising demographic swells. And, you know, there's a hidden fat tax in this country, by the way. Obesity is really expensive, and obesity-associated sequelae are really expensive, and that's across public and private insurance. And so until we can get our nation's health on a better footing, costs are just going to continue to rise.
You touched on behavioral health as a healthcare cost, but what about health behaviors, and what is the role of public health perhaps in helping to modify health behaviors?
It's a really good question. So, I mean, and obesity is a really good example of that, right? I mean, CDC and state and local health departments have had long-standing programs to try to stem the tide of obesity in this country. And if you guys haven't been on the CDC website to look at the obesity stats, there's a series of maps that are about as frightening as the deficit maps, right? Or the deficit charts, because the darker the color and the higher the rate of adult obesity, and you can just see it moving across the states if you look at it in time. There's no state in this country, I think that's right, except one that has an adult rate of obesity that's less than 25%. No state. And I think that's right. I think it's still just Colorado. Right? And in some states, it's 60%. Right? That's not sustainable over time. So I think the arguments for improving population health are real and valid. My concern after 25 years in public health is what can public health do about it? And some of that is because we've been inadequately funded. Some of it is because we're fighting a tide of, you know, 32-ounce sodas. Right? And I honestly don't know the answer to that. Question in the back there.
There's a question here first.
Sure.
I think there's a question here first.
Yep.
Hi, I was wondering, what are your thoughts on single payer?
So whenever I get asked this question, the question was, what are my thoughts on a single payer system? my pat answer is I don't believe we will ever have a single payer system in the United States. I think that the history, the political history of that is far too difficult to overcome in the United States. I mean, look at the fight that we have just had over a market-based system. I'm sorry. This is a market-based system. It's not a government takeover of healthcare one page, right? This is a market-based system. It's not even particularly government-run. It's not government-managed marketplaces, right? So I just don't, if I look at the history of healthcare in the United States and the history of health insurance in the United States, there's nothing that leads me to believe that we will ever have a single-payer system. But I probably wouldn't have predicted Medicare either, right? So who knows? If it gets bad enough, we might end up that way.
So if it's necessary for public health to demonstrate better ROI, to gain more ground, gain more power, what's the problem right now? Or do we have a lack of economic data? Do we have a failure to convince people that the data we have is good data? Or is it too theoretical? What is the barrier?
Those are really good questions. I know there's a whole lecture on those questions. But I think, so there's some things that we do that we don't do very well, right? That even if you had really great data collection systems, we still wouldn't be demonstrating effect. Obesity might be one of those things. On things that we can count, we do, and are easy to intervene, like immunizations, we do a much better job. What's the childhood immunization rate in this country? Like 98%, right? It's really high, except for who? People at the lowest end, often, of the economic spectrum who may or may not have documentation and are kind of afraid to get their kids in the system. And on the other end, it's all these, I'm sorry, wacky college-age parents who think that immunizations are going to give their kids autism and are active non-vaccinators and are counting on herd immunity, although that's not a term we use much anymore, to protect their kids, right? So, but those two tails of the distribution are pretty small. So we have a real, and what's another reason the vaccination rate is so high? Because it's school-based entry, right? And that's why you see such abysmal rates with HPV vaccination, by the way. One of the reasons, because you have to go to the doctor's office 3 times. There's no school requirement, because frankly, if you're doing what you're supposed to be doing in school, you're not at risk for HPV infection. Right? And then there's all these parents who think, oh, it's going to give my kids permission to have sex. So when we had our kids HPV vaccinated, and granted, we're probably not really good examples because we harangue our children about, like, here's how the vaccine was made, and, but it's not like they said, awesome, now I can go out and have sex, right? They were like, oh, it's another shot. That flu shot hurt way more, like that's what they want to talk about. So, I mean, there's a lot of reasons that the system doesn't perform well. Some of them we own, and some of them are just the larger ecosystem in which we're operating. But I will say that over time, and I know there's a divide in the public health community about this, over time, over my time at CDC, I saw a fair amount of what I would call mission creep, right? The roots of public health are in infectious and communicable diseases, and in surveillance and in epidemiology, and we are really good at those things. And some of this other stuff, we are not so good at. Now, the question is, are we not good at it because there are just so many rate-limiting factors that we couldn't possibly be good at it? We are underfunded. We don't have the right skill sets. And, there's a lot of different potential answers to that. But I spent a lot of time trying to explain to policymakers what public health does. And at the end of the day, I'm not sure they got it. If I asked all of you to give me a definition of public health, I bet there would be a lot of different definitions of public health in this room. We have time for one more. One more.
Right there.
I have a question. Do you think the delay and resistance towards the system would go away once the glitches are repaired and people are more educated, or will it continue on?
That's a really good question. So the question was, would I expect to see resistance and complaints about the system reduced? Absolutely, yes. Because it's like any other system. If you roll it out and it's got some hiccups at first, people get, frustrated. Now, the trick will be those people who are right now in the frustrated category, getting them to get back into the system and experiencing a working system. But, I mean, we know, for example, that when people gain health insurance, they're happier, right? I mean, there's really good examples of that with the Oregon Medicaid program, where they did essentially a controlled experiment because they had a lottery to see who got health care coverage. And the people who got health care coverage were, guess what, healthier and happier and more productive than their exact same, control population who didn't. Right? So I think all in all, it's a good thing for people to be able to go see a doctor when they need to.
Thank you, Dr. Ogden. Just a reminder, folks, these get posted. These are recorded and posted. So I don't know exactly what the delay time is, but let your classmates, colleagues, friends, parents, if they want to know what you're up to while they're paying your graduate school tuition, have them click on the link. And please stick around for a little bit outside. Thank you.
Tell them not to call me if they don't like health care.
Or HPV vaccine.
Right. HPV vaccine.
So I'm actually a colleague of